بسم الله الرحمن الرحيم. هنتكلم عن complications of peptic ulcer. معاكم دكتور عمرو فؤاد، مدرس الجراحة في كلية الطب.
Complications of peptic ulcer can be classified into acute complications and chronic complications. Furthermore, acute complications can be classified into bleeding peptic ulcer or perforated peptic ulcer. Chronic complications include obstruction or malignant transformation. We will discuss every type in detail. Bleeding peptic ulcer. First question is, what is the etiology of bleeding peptic ulcer? To know the etiology, you need to know the source of bleeding. According to the amount of bleeding, it can be classified into mild bleeding, which is the most common, moderate bleeding, and severe fetal bleeding, and this is the most rare type. Mild bleeding usually occurs from the granulation tissue in the floor of the ulcer due to trauma caused by food ingested by mouse and hitting the stomach. Moderate bleeding occurs due to erosion of a vessel in the base of the ulcer. And watch the difference. Severe fetal bleeding occurs due to erosion of large extragastric, not on the floor, like the second type, but it's a large extragastric vessel, like splenic or gastroduodenal artery or one of its branches. Second question to know the etiology is asking about the predisposing factors. Predisposing factors for individual to develop peptic ulcer is heavy work, overstress or worry, extremities of weather, and ulcerogenic drugs like non-steroidal anti-inflammatory drugs. Incidence. لو سألنا كام عيان عنده peptic ulcer ممكن يجي ب bleeding peptic ulcer, we will find that bleeding peptic ulcer complicates about 20% of peptic ulcer cases. Clinical presentation. دايما عيان peptic ulcer بيكون عنده past history of dyspepsia لأن dyspepsia is a common feature of peptic ulcer. So, before this patient presents with bleeding peptic ulcer, he will give us a past history of chronic dyspepsia. Anemia is a common feature, a chronic anemia, which may be mild due to invisible bleeding, but it may be severe if this amount increases.
So, when the amount of bleeding increases in moderate cases, patient may present with melena alone or with pylor. While in severe cases with more amount of bleeding, patient would show features of hypovolemic shock, which are pallor, sweating, and faintness. The most important features are hematemesis, past history of hematemesis or ongoing hematemesis, and melena. وهنا لازم نعرف الفرق بين hematemesis and melena. Hematemesis means vomiting of coffee ground material or bright red blood, while melena means passage of black tarry offensive stool. العيان هيقول إن كان عنده vomiting سواء كان لونه bright red أو coffee ground، وهيقول إن لون الستول غير وكان black. investigations. ايه هي اهم investigations ممكن نعملها لعيان bleeding peptic ulcer؟ اهم الانفستيجيشن اللي ممكن تتعمل are imaging investigations like selective celiac angiography زي الصورة الأولانية. بنحاول نرسم الفيسلز ونشوف الستاتس اوف vessel، وده بيخليها beneficial in bleeding peptic ulcer cases. بس بصراحة في الأكيوت setting the most valuable will be upper GI endoscopy. It is the most important investigation for bleeding peptic ulcer. زي في الصورة هنا احنا شايفين spurter from the base of the ulcer in the wall of the stomach, and it may have additional therapeutic value in dealing with the source of bleeding. Differential diagnosis. Bleeding peptic ulcer should be differentiated from other causes of upper GIT bleeding like esophageal varices and bleeding esophageal carcinoma, and this will be discussed later. Treatment. عيان bleeding peptic ulcer لازم نبدأ معاه conservative treatment لأن في الغالب ده بيكون كافي وممكن ما تحتاجش more intervention. Lines of conservative treatment include resuscitation, nasogastric tube, drugs and observation. العيان هيتعمل له resuscitation عن طريق انك تديله IV fluids، تديله blood transfusion بدل اللي اتفقد في الهيماتيمسيس والميلينا، وتديله coagulant drugs زي الفيتامين كي. تاني حاجة nasogastric tube. انت لما تركب العيان ده رايل انت ممكن تأسس البليدنج. الرايل بتعمل سكشن وبالتالي بتقلل احتماليات الانكفالوباثي. تاني حاجة عن طريق الرايل انت ممكن تحقن ايس كولد سلاين، وده في الغالب بيساعد to arrest the bleeding and prepare for endoscopy. لازم تدي العيان ده drugs for peptic ulcer like intravenous H2 receptor blockers، وبتديله antibiotics to guard against infections. Observation. This patient is a critical patient, so it needs close monitoring of vital signs, urine output, central venous pressure, and the amount of bleeding. لو العيان اتدهور منك في أي وقت أنت هتكون محتاج further step. العيان ضغط وقع مرة واحدة، CVB بتاعه وقع، مفيش urine output or very low amount أو severe amount of bleeding, so this patient is not responding for conservative treatment ولازم تفكر في ال other line. تاني حاجة لو العيان ده ما استجابش للconservative treatment انت محتاج تعمل upper GI endoscopy. عن طريق ال upper GI endoscopy انت هتقدر تعرف مكان الألسر، تتأكد انها cause of bleeding، وممكن تعمل endoscopic coagulation of the bleeding ulcer by argon laser or its injection with adrenaline or histoacryl. في الأيام الأخيرة بدأنا نعمل selective infusion للبليدنج vessel، طبعا guided by angiography by gel foam embolization، وده بيقفل البليدنج artery وبيساعد في إنه يقلل البليدنج بصورة كبيرة. آخر حاجة بنلجأ لها في عيان bleeding peptic ulcer هي surgical treatment. طيب امتى محتاجين نتدخل جراحيا في عيان bleeding peptic ulcer؟ أول حاجة failure of conservative treatment، persistent or massive recurrent hemorrhage at hospital. انت حاولت تعمل كل حاجة، حاولت بالconservative treatment، عملت عيان resuscitation، خد الفلويدز والبلاد اللي محتاجها، عملت upper GI endoscopy، ولكن في persistent or massive hemorrhage. تاني حاجة لو انت احتجت انك تنقل blood more than 4 to 6 units في خلال 24 ساعة، وده بالرغم برضو من ان انت حاولت انك تأرست البليدنج عن طريق الاندوسكوبي. This frequent need for blood transfusion is indication for surgical treatment. ثالث حاجة lack of availability of a therapeutic endoscopist or lack of availability of blood for transfusion. طبعا ده هيكون في remote areas. Many or most of tertiary hospitals now have facilities of therapeutic endoscopy and blood transfusion is available. لو العيان ده انت دخل لتاني او تالت مرة، so كل المحاولات اللي انت عملتها
in previous admissions were insufficient, so you should keep in mind that this patient may need surgical intervention. 5. Concurrent indications for surgery such as perforation or obstruction. هنا بنتكلم عن عيان presenting with bleeding peptic ulcer، بس وانت بتعمل investigations تانية اكتشفت ان في complication تانية زي perforation او obstruction، وبالتالي ده هيكون محتاج انك تتدخل. 6. Old age more than 60 years due to atherosclerosis and low cardiac reserve or those presenting in shock. في الغالب العيانين الاولد ايج بتكون فرصتهم قليلة، يعني مش هينفع تحاول معاهم بالكونزرفاتيف تريتمنت والاندوسكوبي لفترة طويلة، فانت بتحاول تلحق العيان تعمل له ديفينيتيف سيرجري وهو ماسك نفسه قبل ما يتدهور منك، او ان العيان ده جاي شوكت ونوت ريسبوندينج للكونزرفاتيف ميجرز، so surgical intervention will be life saving. 7. Long ulcer history as dense fibrosis holds the bleeding vessels open. في الغالب العيانين اللي ما بتستجيبش دي بيكون بيشتكوا من الألسر من فترة طويلة وخد كل أنواع العلاج الممكن، وده نتيجة إن الفايبروزس بيخلي إن يحصل contraction للبليدنج فيسلز قليل جدا، أو إن يحصل كنترول على البليدنج فيسلز عن طريق الاندوسكوبي والأذر ميجرز، دي بتكون فرصته قليلة، وبالتالي ده indication for surgical treatment. 8. High risk lesions like posterior duodenal ulcer with erosion of gastroduodenal artery or erosion of left gastric artery and lesser curvature gastric ulcer or ulcers which are more than 2 centimeters in diameter. لاحظنا في كل الأمثلة اللي فاتت إن بتكون المشكلة في sizable artery، وفي الغالب أول طريقتين قلناهم زي الكونزرفاتيف تريتمنت والاندوسكوبيك انترفنشن مش هيكونوا sufficient to control البليدنج. انت محتاج تعمل surgical intervention علشان تعمل control على source of bleeding. How can we treat bleeding peptic ulcer surgically? According to the general condition of the patient and source of bleeding. First, in case of bad general condition, we would stop bleeding and no more. Like bleeding from the eroded blood vessel at the base of ulcer is treated by underrunning suture. يبقى لو العيان حالته مش مستقرة انت هتحتاج تعمل مانوفر in short duration لمجرد انك توقف البليدنج، بس مش هتعمل definitive surgery لان حالة المريض والوقت مش هيسمح لك انك تاخد long operative time. ففي الحالة دي انت هتضطر انك تاخد underrunning sutures لحد ما توقف البليدنج في البيز of the ulcer. تاني حاجة in case of good general condition definitive ulcer surgery would be beneficial. يعني في حالات الجاستريك ulcer انت هتعمل partial gastrectomy including the ulcer، وبعد كده هتحتاج تعمل bypass بالطرق اللي احنا هنقولها بعد كده. لو في duodenal ulcer انت هتاخد برضو underrunning sutures in the ulcer، بس هتحتاج تعمل vagotomy لان هو ده المين كيز، الفيجاس انرفيشن لازم تقطعه. وللاسف ان احنا لما بنعمل truncal vagotomy يعني لما بنقطع الفيجاس at a higher level بنكون محتاج drainage operation. يعني ايه؟ يعني انت قطعت الانرفيشن بتاع البايلورس، فمش هيحصل ان البايلورس هيشتغل بصورة طبيعية، فانت لازم تعمل drainage بصورة او اخرى علشان العيان ده ما يحصلش stasis ويحصل obstruction والقايم مش هيعدي من الاستومك للسمول انتستين، فبالتالي انت محتاج تعمل drainage operation. من اشهر الدرينج اوبريشن هي البايلوروبلاستي. البايلوروبلاستي ده بنعمل transverse incision في البايلورس then we will close longitudinally، ودي طريقة مشهورة انك توسع any luminal structure. Prognosis. The prognostic factors. The prognostic factors for
bleeding peptic ulcer patients are 1. Age of the patient, 2. Amount of bleeding, 3. Time factor, 4. Frequency. أكيد العيان old age هيكون prognosis بتاعه أسوأ من عيان young age علشان atherosclerosis و low cardiac reserve and all comorbidities which may present. تاني حاجة amount of bleeding. أكيد لو العيان نزف كمية كبيرة واحتاج transfusion لأكتر من 6 units of blood, it carries bad prognosis. time factor. إن العيان يجي بأتاك واحدة ونزف فيها moderate amount أو large amount، ده أسوأ كتير إن يكون العيان ده فقط كمية أكبر بس على long time. يعني لو العيان حصل له attacks of minimal bleeding على 3 أيام let's say، ده هيكون أحسن كتير من إن هو يفقد مرة واحدة كمية أكبر كذا لتر من البلد في الهيماتيمسيس والميلينا في يوم واحد. الفريكونسي أكيد بتأثر. العيان اللي جايب فيرست أتاك اوف هيماتيمسيس أكيد بيكون مصيره أحسن كتير بالعيانين اللي بيجوا in third and fourth attacks. The second complication of peptic ulcer is perforation. Perforation usually occurs due to ischemia, which leads to sloughing of the base and later on perforation. This initial ischemia is caused by end-arthritis obliterans. The same factors causing exacerbation of the ulcer are risk factors for ulcer perforation, like work, heavy work, worry, weather, drugs like analgesics, increase in intragastric pressure in case of heavy meal and straining, and lastly sodium bicarbonate. Pathology. Ulcers which usually perforate are commonly found on anterior aspect of the duodenum or anterior aspect of lesser curvature. Rarely, a posterior ulcer may perforate into the lesser sac. What are stages of perforated peptic ulcer? 1. Stage of perforation. Peritoneal, it causes peritoneal irritation and it lasts for 2 to 6 hours. In this stage, it occurs a sudden escape of irritant gastroduodenal contents in the peritoneal cavity, results in intense chemical irritation. Stage of peritoneal reaction, lucid interval. في الستيج دي الجسم بيبدأ يتعامل مع escaped gastroduodenal contents عن طريق secretion of copious amount of peritoneal fluid، وبالتالي بيحاول يعمل dilution. This stage is invariably followed by diffuse septic peritonitis. بعد ما المريض بيعدي باللوسيد انترفال بيحصل diffuse septic peritonitis لو ما حصلش dealing بصورة سريعة مع البرفوريشن. Length of this stage depends upon many factors زي size of perforation and fullness of the stomach. يعني اللوسيد انترفال تطول أو تقصر على حسب السايز of perforation. لو perforation قليل بالتالي اللوسيد انترفال هتكون طويلة، والعكس لو perforation كبير اللوسيد انترفال هتكون قصيرة. fullness of the stomach لأن ده بيحدد ال amount of escaped gastroduodenal contents. ففي اللارج perforation هيبقى فيه large amount of escaped gastroduodenal contents وبالتالي اللوسيد انترفال هتكون قليلة. أما في ال small perforations this amount of escaped contents will be small and so longer lucid interval. برضو ال general condition of the patient بتحدد length of lucid interval. يعني patient with good resistance and general with good resistance and good general condition will have longer lucid interval. Site of perforation is another factor which determines length of lucid interval, as it's longer in duodenal ulcer than gastric ulcer with better prognosis due to small size, high acidity and empty stomach. ده طبعا احنا شايفينه لوجيك لان اكيد لان البرفوريشن الكبير اكيد هيكون اللوسيد انترفال بتاعته قليله والبروجنوزس بتاعته أقل، وفي الغالب ده بيكون gastric perforation. أما الduodenal perforation بيكون smaller in size وليه factors كتير تخلي البروجنوزس بتاعه أفضل. Also in duodenal ulcer the contents pass along paracolic gutter to right iliac fossa, while in gastric ulcer the contents pass freely to general peritoneal cavity. يعني نقدر نقول ان duodenal ulcer هترمي في بوكيت صغيرة، وبالتالي هيبقى localized peritonitis ده على حسب الاناتوميكال سايت. اما في الجاستريك ulcer الكونتس can pass to peritoneal cavity as a whole، وبالتالي البريتونيتس هيكون أعنف والبروجنوزس هيكون أسوأ and زي ما قلنا shorter lucid interval. بعد كده stage of diffuse bacterial peritonitis or septic peritonitis، ودي بتحصل لما body resistant fails، بيحصل diffuse purulent inflammation، خلاص الجسم ما عادش قادر ان هو يواجه this sepsis فبيحصل diffuse inflammation. Incidence of perforated peptic ulcer. It complicates about 10 to 20% of peptic ulcer cases. It's common in middle age, from 40 to 60 years, male individuals. Clinical presentation. زي ما قلنا ان الألسر dyspepsia is a common feature for peptic ulcer, so our patient would give us a history of chronic ulcer dyspepsia which is positive in about 75% of cases. على حسب الستيج هيكون الكلينيكال picture. في الأول sudden severe agonizing pain appears in the epigastrium. Patient may pass in shock with pallor, sweating, subnormal temperature and tachycardia. و abdominal examination هنحس board like rigidity. تاني حاجة in stage of lucid interval the patient feels false improvement and looks better as pain diminishes and temperature rises. But tenderness and rigidity persist. Masked hepatic dullness by escaped gas may be detected. يعني في جاز بيكون طالع من البرفوريشن، فالنورمال هيباتيك dullness اللي احنا بنحسها النورمال individual would be masked and replaced by resonant area. Shifting dullness may be elicited وده طبعا نتيجة الفلويد which has escaped into peritoneal cavity. In a stage of diffuse septic peritonitis which occurs 6 hours later, the pain returns, which is severe in character, with fever, tachycardia and repeated vomiting. هيكون في marked abdominal distension and rigidity and rebound tenderness. Abdominal distension with shifting dullness will continue. This is by percussion, and by auscultation intestinal sound would disappear. It would be a dead silent abdomen. Investigations. First, laboratory investigations like CBC will show leukocytosis, rise of white blood cells. Imaging, plain X-ray of the abdomen or better chest X-ray in erect position will show gas under diaphragm as in this picture. Is the black opacity here is gas under diaphragm, and here this is a normal chest X-ray with no gas under diaphragm. In negative cases, insufflation of 400 ml air through nasogastric tube may render them positive. يعني في بعض الأحيان بيكون الجاز مش sufficient إن هو يبان في الإكس راي as gas under cupola of diaphragm. وفي الحالة دي لو احنا شاكين بالكرايتيريا التانية إنها perforated peptic ulcer فاحنا بنحاول نزود الأير which could escape through the perforation by injecting 400 ml air through the NGT. If the patient can't stand, X-ray may be taken in the left lateral position and it will show gas in the axilla. في بعض الحالات البيشنت بيكون حالته العامة سيئة جدا لدرجة ان هو ما يقدرش يقف علشان ناخد فيلم erect and do plain erect X-ray. في الحالة دي بنخلي البيشنت ينام على جنبه و في ساعتها البرفوريشن express itself as presence of gas in the axilla.
Sometimes we will need to use contrast by doing perimeal, and in this case we will find that there is escape of dye through the perforation, but it carries many hazards because letting an irritating chemical entering the peritoneal cavity is very dangerous. By abdominal ultrasound, a turbid fluid may be found in peritoneal cavity. Normally, no free fluid is found in the peritoneal cavity, but in case you found a turbid fluid in the peritoneal cavity, it denotes that there is an abnormal content which usually with other features supporting the presence of perforated peptic ulcer.
Differential diagnosis. Perforated peptic ulcer بتعمل a case of acute abdomen, so it should be differentiated from other causes of acute abdomen, especially acute pancreatitis, which also presents as the gastric pain. Treatment. First line of treatment is resuscitation. This patient is a risky patient who may pass into shock stage at any time. So you should resuscitate by intravenous fluids, blood transfusion, antibiotics, and nasogastric suction, the same lines of conservative treatment used in bleeding peptic ulcer. Second, conservative treatment or non-operative management. It's indicated only in poor risk patients unfit for surgery. It is not recommended for routine use. It includes the resuscitation as before with close observation for the hope of spontaneous closure and localization of infection. صراحة الاوبشن ده اوبشن مش ظريف جدا لان انك تسيب perforated peptic ulcer without operative intervention ده لازم تكون مجبر عليه بصفة كبيرة، يعني يكون البيشنت الجنرال كونديشن بتاعته ما تستحملش اي تدخل خالص، واي تدخل هيكون فيه خطورة سواء في من ناحية الاوبراتيف تروما او من ناحية الانستيزيا، فبالتالي ممكن تسيب العيان ده under observation على امل ان البرفوريشن يقفل لوحده. Surgical treatment for perforated peptic ulcer. It is a treatment of choice. It should be done as soon as patient is resuscitated. It depends upon the general condition of the patient. In bad general condition, simple closure and no more. Simple closure is done with 3 interrupted full thickness sutures over Graham's omental flap. يعني ايه؟ يعني احنا بناخد 3 غرز علشان نقفل بيهم البرفوريشن like this picture. خدنا 3 غرز قفلنا البرفوريشن وبعدين بناخد جزء من الاومنتم which is called omental flap. This is a part of omentum which has been pulled up here over the perforation to cover it and reinforce our repair. بصراحة in very bad condition we can do a more simple maneuver which is just drainage. The peritoneum is irritated by gastrointestinal escaped content, so we can do 2 incisions into right iliac fossa and left iliac fossa to help drainage of the escaped gastrointestinal content. Then let the patient improves and close monitoring. After the general condition improves, a definitive surgery for perforated peptic ulcer can be done. In good general condition, definitive surgery can be done. يعني لو المريض جاي في حالة كويسة من الأول at early stage, some prefers to do definitive surgery at the first scene. زي in this first picture, partial gastrectomy of the part including the ulcer was done, and then gastrojejunostomy has been done to re-establish continuity from the stomach to small intestine. In this second picture, distal gastrectomy was done and Perlos type 1, which means gastroduodenostomy, has been performed. In this last picture, it's a Perlos type 2, which means distal gastrectomy and gastrojejunostomy instead of gastroduodenostomy in this picture. Prognosis of perforated peptic ulcer. The mortality rate is about 15%. بصراحة دي نسبة عالية إن 15% من عيانين perforated peptic ulcer في الغالب ما بيعدوش due to late presentation and complications.
The third complication of peptic ulcer is chronic obstruction. In case of duodenal ulcer obstructing gastrointestinal tract, it's called gastric outlet obstruction. Etiology: cicatrization of duodenal ulcer. Pathology: the pylorus cicatrized and stenosed. نلاقي البايلورس فيه fibrosis وهيكون أضيق من الطبيعي. The stomach at first hypertrophies, then it fills and dilates. The huge dilated stomach may reach the pelvis. The small intestine free and collapsed. هنا هنلاحظ انه مشي مع قاعدة أي obstruction, proximal dilatation and distal collapse. What are the complications of chronic gastric outlet obstruction? First, metabolic hypercholoremic alkalosis due to chronic hydrogen and chloride loss. هنلاقي انه بيحصل alkalosis لان ال HCl هيكون lost in vomiting وبالتالي هيحصل metabolic alkalosis as a compensatory mechanism. هيحصل electrolyte deficit in the form of hyponatremia and hypokalemia. هيحصل dehydration and maybe pre-renal anuria, loss of body weight and hypovitaminosis. In case of antral stasis هيزيد الجاسترين هرمون وبالتالي هيكون فرصة تكوين ألسرز جديدة ممكنة. هيحصل respiratory infection pneumonitis due to inhalation of vomitus. ده طبعا في severe cases. Clinical presentation. زي ما قلنا في كل types of complications إن في history of chronic ulcerative dyspepsia in almost all cases. Epigastric distension occurs especially after meal. ده طبعا نتيجة obstruction. Vomiting occurs with the following criteria. It would be projectile, not bile stained لأن obstruction above the level of cone bile duct insertion into duodenum. It would be foul odor, contains old food which is gastric content, and relief occurs after vomiting. Also, as a result of obstruction, it would be progressive constipation present, visible peristalsis in the epigastrium from left to right, succussion splash may be elicited, and picture of more complications like dehydration, tetany, and electrolyte deficit, which are all complications of obstruction due to vomiting or malabsorption. What are the proper investigations which could be done in case of chronic gastric outlet obstruction? First, saline load test. In this test, 700 milliliter of saline is infused through Ryle's tube. After 30 minutes, if more than 350 ml is aspirated, so obstruction is diagnosed. It is useful for follow-up. بمعنى انك ممكن تعيد التست ده وتشوف ال amount of aspirated saline again. If it is less than 350, so it's improving, and calculating the serial amount of aspirated saline would help us in follow-up. The second, which is the more important than this load test, is barium meal. Barium meal in case of chronic gastric outlet obstruction may reveal the following: hugely dilated stomach, which may reach the pelvis, and it may take the J-shaped stomach. Let's erase. The second finding may be a fluid level in the stomach, giving soup plate appearance. It is characteristic for obstruction. This is the air fluid level found. We will erase again to show another finding for barium meal. Delayed evacuation of barium is also characteristic of chronic gastric outlet obstruction, and remnants of barium may still in the stomach after 24 hours. This is the level of obstruction, so evacuation of barium would be delayed from here to here. Yes, evacuation of barium would be delayed. This is the level of obstruction, and remnants may still in the stomach from barium after 24 hours. By taking a general look, this is the shape of barium meal in case of gastric outlet obstruction. The third important investigation is endoscopy. Upper GI endoscopy may fail to pass to the duodenum لما يكون عندك obstruction في البايلوريك area، بالتالي المنظار مش هيعدي to the duodenum لأن السكة مقفولة. It may exclude malignant obstruction as by endoscopy you can detect any external compression or over the duodenum or intraluminal masses. Endoscopic hydrostatic balloon dilatation can be performed. يبقى دي therapeutic benefit ان انت ممكن وانت جوه بالمنظار انت داخل بيه اصلا diagnostic but you may use it as a therapeutic tool by doing dilatation. Serum electrolytes, which is a laboratory investigation, can be used to detect electrolyte and acid-base imbalance, which are common complications in case of obstruction. Differential diagnosis. Gastric outlet obstruction should be differentiated from other causes of obstruction, especially malignant one, and this will be discussed later. Treatment. ازاي هنتعامل مع حالة gastric outlet obstruction؟ في الأول conservative treatment would be an option, and it is indicated in the following. In mild cases, in case of only pyloric spasm, which may relieve after conservative treatment. Second, in cases which are unfit for surgery, it occurs in presence of many comorbidities or vaginal condition, and conservative treatment includes the following lines. First, nasogastric suction through nasogastric tube with gastric lavage to decompress the stomach and regains its tone, allow pyloric edema and spasm to subside. انت عندك مشكلتين، عندك edema وسبازم في البايلورس تحت، وعندك فوق distension في الاستومك. انت محتاج تعمل decompression للاستومك عشان ترجع التون للوول بتاعها، ومحتاج ان البايلوريك اديما دي تقل والسبازم يقل علشان الموتيليتي ترجع نورمال. النيزوجاستريك تيوب بتسهل لك الموضوع ده علشان هي بتعمل aspiration لكل ال obstructed fluid inside the stomach. بعد كده ممكن تعمل سالين لود تيست اللي احنا قلناه قبل كده علشان تعرف البيز لاين بتاعك قد ايه، وتبدأ تعمل فولو اب وتشوف الاسبيريتد سالين اللي طالع في ال NGT اقل او اكتر، فده بيتيح ليك الكومباريزون اند فولو اب. هتعمل correction electrolytes or fluid deficit through intravenous fluids fortified by electrolytes. في حاجة مهمة ان احنا المريض ده لازم ياخد nutrition لانه مش قادر ياخد ال oral nutrition الطبيعية بتاعته نتيجة ال obstruction and repeated vomiting، فبالتالي total parenteral nutrition would be a choice for chronic malnourished cases. 72 hours later, saline load test is repeated. If it shows good improvement, the nasogastric tube is withdrawn and the liquid diet begins, followed by gradual resumption of solid food. Once النهاية اتحسن، انت عايز تبدأ له oral diet as soon as possible، لكن انك تبدأ فجأة او مرة واحدة مش هيكون option كويس، فبالتالي احنا بنبدأ sips of water وبعدين بنبدأ soft diet ونبدأ نزود gradually till patient returns to his normal life. Surgical treatment is the most effective in most cases of chronic gastric outlet obstruction. First, you will need to prepare this patient properly. Second, the procedure will depend upon the age and general condition of the patient. If old patient with bad general condition, you will only relieve the obstruction by gastrojejunostomy, which is a simple maneuver. Pyloroplasty can't be done in this case due to marked fibrosis in the pylorus. If young patient with good general condition, so you can do definitive ulcer surgery, as we said before, vagotomy and gastrojejunostomy as a drainage operation, or subtotal gastrectomy and Perlos type 2. Then we will talk about hourglass deformity. In case of cicatrized gastric ulcer, stomach will take the shape of teapot or hourglass. This is the level of ulcer, and this is the hourglass stomach by presence of proximal pouch and distal pouch. So let's erase all this. Clinical picture and complications would be the same as pyloric obstruction. Investigations would include barium meal showing the persistent deformity and endoscopy. In case of endoscopy, when endoscopy reach the site of cicatrized ulcer, it would see the narrowing and the deformity with presence of proximal and distal pouch would be apparent. In case of barium meal, the persistent deformity is also apparent by presence of proximal and distal pouch, and this is the site of narrowing of the cicatrized ulcer. So this is the appearance of hourglass or teapot stomach. Treatment of hourglass stomach is mainly surgical. It depends also on general condition of the patient. In case of bad general condition, gastrojejunostomy can be done, anastomosing the proximal pouch to the jejunum, like in this first picture. This is the site of anastomosis. Alternatively, gastrostomy by anastomosing the proximal and distal pouches can be done, but it is not familiar and it carries technical difficulty and many complications, so gastrojejunostomy is a proper choice. In case of good general condition, partial gastrectomy by removing the distal pouch and the isthmus would be beneficial. Then you can choose any maneuver to re-establish continuity of gastrointestinal tract. In this figure, partial gastrectomy can be done if we consider this is the level of cicatrized ulcer, so partial gastrectomy can be done, and then gastrojejunostomy to re-establish continuity. We will erase all this. Okay. This figure below shows another types of re-establishing continuity by Perlos type 1, which means gastroduodenostomy after partial gastrectomy, or Perlos type 2, which is gastrojejunostomy. Thank you for attention.